and welcome to SureenaSpeaks. And in this B&F bite-sized style video, I'm going to be covering two really key topics of the GI system. That is constipation and diarrhea, something which I think all of us have experienced at some point or another in our lives. If you do want to know about more conditions that affect the GI tract, then do make sure to check out my SureenaSpeaks GI video. And I hope that you do enjoy this video, and if you do, please do give it a thumbs up, share, like, and hit that subscribe button. Also make sure to check out my Facebook, Instagram, and Twitter. So let's start off with constipation. So with constipation, especially if it's not necessarily severe, it hasn't lasted for too long, and in general we always want to be able to give lifestyle advice. Remember, we're not just there to give advice on medicines and counselling points to medicines, it is also to give that all important lifestyle advice as well. So if a person has constipation, then they should increase their fibre uptake. They should also try juices, fruit juices high in sorbitol, so for example apple juice, fig juice. Also ensure that they're having adequate fluid intake as well. Really important that they exercise, have a balanced diet, so ensuring that they're incorporating whole grains, fruit and vegetables all into their diet. Now, if we're talking about laxatives, it's important to note that laxative abuse can lead to hypokalemia. Now, how I started revising this topic and the way that I would recommend it is actually getting a piece of paper, splitting it into sections, into fours, and then in each section putting in there the group of the laxative, the onset of action, some example types, and any additional counselling points. And then putting that poster, sticking it somewhere where you will see very often, and ensuring that you absorb that information that is in front of you. So let's start off with fecal softness. So with fecal softness, examples include docusate, which also has a stimulant element as well, can also act well as a stimulant. Glycerol suppositories are another one. They have a lubricant and a rectal stimulant action too. And both docusate and glycerol have softening properties. Now, fecal softeners usually are the fastest acting, especially when they're in a suppository form. So if we take docusate oral preparations, for example, they can work in 1 to 2 days, which is still very fast. But if we compare it to the suppositories, actually it can take as quick as 20 minutes for it to take action. There are enemas as well, but it's worth noting that some enemas do contain arachis oil. So if someone has a peanut allergy, this is something that we want them to stay well away from. But with enemas, they do have a lubricating action, they can soften impacted feces, and they do promote a bowel movement as well. There is also liquid paraffin. Liquid paraffin doesn't really tend to be used very often because of the adverse effects that it does have, but it's one to note that it does have a lubricant effect as well. Then we move on to the stimulant laxatives, and these are the next fastest acting. Examples include senna, bisocodal, sodium picosulfate, codanthroma, and codanthrosate. With our senna tablets, they act in around 8 to 12 hours, whereas our bisocodal tablets can take about 10 to 12 hours. Saying that, our bisocodal suppositories, remember we mentioned suppositories are faster acting, they can take about 12 to 60 minutes to have an effect. And with the stimulants, they increase intestinal motility. So as they're doing so, they can cause abdominal cramping. So this is a key side effect to make our patients aware of. With codanthroma and codanthrosate, their use tends to be limited to those who are terminally ill due to the potential risk of carcinogenicity and genotoxicity. Some big words there. So the next one that we're going to look at is osmotic laxatives. So for example, lactulose, macrogols. And when we think of osmotic laxative, we think osmosis, we think water. So essentially what it's trying to do is increase the amount of water that is in the large bowel. And it can do that in one of two ways. It will either draw fluid from other parts of the body into the bowel, or it will retain fluid that the individual was already administered with. And it usually takes around 48 hours for it to work. Something like lactulose can also be used for hepatic encephalopathy. Now, because we're taking fluid from other parts of the body, a really key counselling point with macro goals is to ensure that the patient does have adequate fluid intake so that it reduces any potential dehydrating effects that these osmotic laxatives can cause. The next one we're going to look at is our bulk forming laxatives. And with our bulk forming laxatives, we have, for example, bran, aspergillus husk, never know if I'm saying that correctly, but let's just go along with it, and methyl cellulose. And methyl cellulose also has a fecal softening effect. Now, of all of the laxatives that we've spoken about today, it's the bulk forming laxatives that actually have the longest onset of action, around 72 hours. They're useful in adults with small hard stools and for those who can't increase their dietary fibre intake. In general, in the case of constipation, if those non-pharmacological methods, which we mentioned right at the beginning of the video, don't work or they're not getting much of an effect, then the next first line would be to go with a bulk forming laxative. Some side effects though do include flatulence, bloating, abdominal cramps, so beautiful things. And a key counselling point to give to patients who are on bulk forming laxatives is that they do ensure that they have good, adequate fluid intake to avoid any intestinal obstruction. So we mentioned that if non-pharmacological methods aren't providing the patient with much benefit, then we can switch them onto a bulk forming laxative. If, however, the patient still has hard stools with a bulk forming laxative, then we can either add or switch to an osmotic laxative. If with an osmotic laxative, the patient is still, their stools still aren't soft enough or they complain of inadequate emptying, then we can add on a stimulant laxative. So there's two other medicines which we've not really mentioned, which is linaclotide and prucalopride. So linaclotide is used in moderate to severe irritable bowel syndrome associated with constipation. And prucalopride is very much used as a last resort. So in patients with chronic constipation where treatment with every other type of laxative has failed, then as that last resort, prucalopride would then be the go-to. So similar to that short duration constipation, nice little rhyme there. In the terms of chronic constipation, if those non-pharmacological methods weren't providing enough benefit, you would add on a bulk forming laxative. If stools were still hard, then you would add on an osmotic laxative, preferably macrogol, but if that was ineffective or inadequate, then or not tolerated, then try lactulose. If there was still not enough benefit, then you would add on a stimulant laxative. And in a patient who has been on 2 or more laxatives from different classes for 6 months and they still have constipation, that's when then prucalopride would be tried, and it's used in this instance for women only. In the case of opioid-induced constipation, typically an osmotic laxative and a stimulant laxative will be given together. Sometimes docusate might be as well if a stool softening effect is required. If you look for example, in a hospital, you may notice patients who are on opioids, they're usually co-prescribed lactulose and senna, and this will be the reason why. Bulk forming laxatives should usually be avoided in patients with opioid-induced constipation. If you refer to the BNF constipation section, and particularly prescribing palliative care, there is more information on this. Now, naloxegol, again, funky names, and methyl naltrexone, they're both used in the treatment for opioid-induced constipation when other laxatives have been inadequate. In terms of pregnancy, again, our first go-to would be dietary, lifestyle advice. We can advise fibre supplements as well. If these measures fail, then the next recommendation would be a bulk-forming laxative. An osmotic laxative can also be recommended, such as lactulose, but our bulk forming would be the next go-to. In terms of stimulant laxatives, they can also be given. Something like senna, though, should be avoided when a patient is near term. And even though stimulant laxatives are more effective than bulk forming laxatives, because of those side effects of abdominal discomfort, cramping, it does sometimes put patients off wanting to use those stimulant laxatives. Docusate suppositories, glycerol suppositories, they can also be used. In terms of breastfeeding, again, if those dietary lifestyle measures fail, then next go-to would be bulk forming laxative, although we could recommend an osmotic laxative as well. In terms of our stimulant laxatives though, if this was recommended, then it would need to be a very short course. So we've been saying that with constipation, those non-pharmacological methods are sort of the first go-to. Well, when it comes to children, actually, diet modifications and a laxative together, that is actually first-line treatment, not just dietary modifications on its own. So we want to ensure that children are increasing their fruit and fibre intake, eating foods such as high-fibre bread, baked beans, whole grain cereals, but also first-line management would be giving a macrogol. Now, if a macrogol was ineffective, then we could add or switch to a stimulant laxative. If stools were still required more softening, then we could also provide something like lactulose or another stool softener such as docusate. So children with chronic constipation, they might be on laxatives for several weeks until a regular bowel movement or bowel pattern has been established. When it gets to that point, laxatives can then start being tapered off, but it must be done so very slowly, could even be done over several months. So we've spoken a lot about constipation. Let's go to the other end of the spectrum, which is diarrhea. So diarrhea, acute diarrhea, is one that lasts less than 14 days and where symptoms improve within 2 to 4 days. So there are many reasons why a person might have diarrhea. It could be a side effect of a medicine, for example, clindamycin, which in the case of clindamycin, that's actually a really severe side effect. The clindamycin would then need to be discontinued and medical attention sought ASAP, especially if it was persistent diarrhea with clindamycin. Diarrhea could also be associated with different conditions such as irritable bowel syndrome, irritable bowel disease. It could be gastroenteritis, eating a dodgy kebab on a Friday night. I mean, there are so many different reasons why a person might get diarrhea. But if a person has any red flag symptoms, that's when we would need to investigate further. So this could include any unexplained weight loss, persistent diarrhea, any bleeding, rectal bleeding, for example, or if a person has been traveling abroad recently and they've come back and they've had diarrhea. So how long a person has had diarrhea for usually accounts for whether they need referral or not as well. So typically with both adults and children, if a person has had diarrhea for, say, more than 7 days, that would warrant referral. So in most cases of diarrhea, it will settle on its own accord. We could recommend something like oral rehydration sachets, because it is important that if there's any dehydration that the diarrhea has caused, that we're giving those supplementing and giving that appropriate treatment and oral rehydration that the patient needs. If it's the case of severe diarrhea though, and the patient can't take in or consume any fluids, then they would need to be administered to hospital. They would need urgent replacement of fluids. They'll be hooked up to an IV line so that those rehydration fluids could go into their system. There is also loperamide, which is an anti-motility drug, and it's usually used as the standard medicine when rapid relief of symptoms of diarrhea is required. So, for example, if you have a patient who has traveller's diarrhea, that's when loperamide should be and would be used. It should be avoided in case of bloody diarrhea or if there's any suspected inflammatory diarrhea. There is also a medicine called racecadotril, and this can be used as an adjunct to rehydration for the symptomatic treatment of uncomplicated acute diarrhea in adults and children over 3 months. Now, based on NHS guidance, they recommend that anyone with diarrhea, first and foremost, have some rest. Make sure that there's adequate fluid intake, whether that be water or squash, and if needs be, to take paracetamol as well for any pain or discomfort. So I hope you enjoyed this BNF bite-sized video on constipation and diarrhea. As I mentioned at the beginning of this video, if you want to know more about either of these two topics or about any conditions related to the GI tract, then do make sure to check out my SureenaSpeaks GI video. Please do hit that subscribe button and Please do support the video. I really do appreciate all the love you give. Until next time, good luck with your revision and happy revisings.